Hit the subscribe button or visit us at auau.auanet.org.
Thank you, Dr. Borgen. That was a great talk. I'm excited to carry that torch forward and discuss imaging of advanced prostate cancer. My name is Kelly Stratton. I'm an associate professor at the University of Oklahoma. Here are our learning objectives. We're going to look at the role, the indication, and techniques for imaging patients with known or suspected metastatic prostate cancer. We'll also characterize and compare current molecular imaging modalities. So, as mentioned, the guidelines have an approach to imaging in different clinical situations. We'll consider patients who have biochemical recurrence, those with metastatic hormone-sensitive prostate cancer, those M0 or non-metastatic castration-resistant prostate cancer patients, and those with metastatic CRPC. Principles for imaging at recurrence. As already mentioned, imaging is an option for patients who have a PSA recurrence. You're going to be evaluating for the presence of metastatic disease, particularly patients who are at risk due to their overall PSA or their PSA kinetics. So for instance, the PSA doubling time less than 1 year. For patients who have PSA recurrence, obtaining periodic imaging with cross-sectional studies such as CT or MRI, and then a bone scan is what's recommended as the initial step. And again, bone scan and CT scan are what are considered conventional imaging. That technetium bone scan is a cheap and easy way to evaluate the bones for metastatic areas. It is time consuming, takes 3 to 4 hours to obtain for each patient. CT scans, CT chest, abdomen, and pelvis, also cheap and easy to obtain, evaluating both visceral and lymph nodal metastasis, and then also bone lesions occasionally. So the strength of the CT scan is that ability to look for nodal metastasis and then lungs, liver metastasis as well. The weaknesses, it can be difficult to detect bone lesions. It's sometimes hard to know whether that's a metastatic area or a bone island. And the limited detection for nodal metastasis, specificity is about 80%, but sensitivity is only 40%. For the technetium bone scans, they're highly sensitive for osteogenic activity. So it's a quick assessment of the entire skeleton. However, their specificity is low, especially if the PSA levels are low. For patients who have negative conventional imaging, you can consider novel PET scans such as fluciclovine, choline, or PSMA. And so we'll be talking about those novel imaging opportunities. This is definitely a time of change between what has been conventional imaging and what is now considered next generation imaging. So in the future, many of these opportunities to image patients may change based off of new imaging opportunities. For patients with metastatic hormone-sensitive prostate cancer, they should undergo an assessment of their disease burden. Using conventional imaging is what we have used in clinical trials to determine disease volume. So high volume versus low volume, particularly that definition of high volume disease is 4 bone metastases with at least 1 outside the spine or pelvis, or the presence of visceral metastasis. Then during treatment, patients will receive periodic imaging to make sure that there have been no changes as well. In M0 CRPC, conventional imaging is often recommended every 6 to 12 months. That's based off of their PSA doubling time, the presence of symptoms, or any changes in the status of the patient. Once they're on androgen receptor targeted therapy, annual imaging should be sufficient. For these patients, we do continue to recommend imaging because we know in patients who have, for instance, castration-resistant prostate cancer with metastasis, that even if their PSA was low, like on the PREVAIL trial where patients were receiving enzalutamide, that up to 25% of them may have disease progression on imaging without changes in their PSA. So there is still a potential for progression even if the PSA is low. For patients with castrate-resistant prostate cancer, the imaging recommendations are based off of the results of the clinical trials working group 3. So the recommendation for CT scans and bone scans are based off of this prostate cancer working group. For patients who have consideration for neuroendocrine transformation, an MRI of the brain or CT of the brain may be necessary as well. So there's a low threshold for imaging the brain in addition to that CT and bone scan. Re-imaging every 3 to 12 months is recommended, and that can be increased in frequency based off of the PSA, also the presence of symptoms. Anytime a patient comes in and it seems like they're experiencing new symptoms or a change in their clinical status, you'll want to repeat the imaging. The Prostate Cancer Working Group 3 also recommends incorporating the RaDaR 3 guidelines for next generation imaging. So in this graph, you see the recommendations for conventional imaging in the darker blue, and then next generation imaging down below in the green. So for a newly diagnosed patient, particularly those at high risk for metastasis, conventional imaging with a CT scan and bone scan is recommended if their PSA is greater than 10, Gleason score greater than or equal to 7, or palpable disease. However, if there's concern that the patient may still have metastasis even in the presence of negative conventional imaging, the RaDaR 3 group would suggest that next generation imaging may be an option. For patients who are biochemical recurrent, the first conventional scan is recommended at a PSA level between 5 and 10, with a follow-up when it doubles or a PSA of 20. In the RaDaR 3 guidelines for next generation imaging, you may want to consider one of these advanced PET options when their PSA is greater than or equal to 0.5. So the level of detection is greatly improved with these next generation imaging options. If you have, for instance, PSMA PET, you may even be able to go below 0.5. For patients who have castrate-resistant prostate cancer that is non-metastatic or M0 CRPC, the first conventional scan is recommended with a PSA level greater than or equal to 2, with periodic imaging thereafter. However, if their PSA doubling time is less than 6 months, the RaDaR 3 guidelines suggest you may want to use next generation imaging to ensure that the patients aren't M1. So when we speak of these next generation imaging and PET imaging, we are not talking about FDG PET. That's the everyday PET that oftentimes is used by medical oncologists. FDG PET has limited utility in prostate cancer patients because of relatively low glucose metabolism. It may perform a little bit better in castrate-resistant prostate cancer, but still, we do not incorporate FDG PET imaging as one of these next generation images. So just as a comparison of a bone scan versus an FDG PET, the bone scan shows a thoracic vertebral lesion. And while you can see it on the CT part of the PET scan, there's really no activity from the FDG PET scan. So there are several additional imaging options as included in the next generation imaging. From the PET perspective of PET CT imaging, there's sodium fluoride PET, C11 choline PET, fluorocholine PET, and synthetic amino acid PET tracers and PSMA targeted tracers. There's also whole body MRI. So PET scan is basically just using a molecule that is targeted to, in this case, prostate cancer, and then tagging that molecule to a positron emitting tracer. And these can be interchangeable. So you have, for instance, fluciclovine PET or choline PET or PSMA PET, and then depending upon what the tracer is, that's the F18 or the gallium or the choline. Regardless of these tracers, the principles are the same. Target the cancer and get something to emit energy that can be detected for the CT scan or the MRI. The tracers, though, dictate how easy it is to use each kind of PET imaging. So these are the three options that we have: carbon 11, fluorine 18, or gallium 68. And you can see the half-lives are markedly different between these agents. So, for instance, the carbon 11 has a 20-minute half-life, requires a cyclotron to develop, and so it needs to be on site because of the short half-life. Whereas F18 has a 110-minute half-life and gallium has a 68-minute half-life. So these agents can be sometimes generated off-site and then taken to the imaging center. Again, considering the RaDaR 3 guidelines, there are 3 PET imaging options that we'll really want to highlight because they're probably the most likely to be available either currently at your site or in the near future. Flucyclovine PET or Axon PET is an amino acid transport target that specifically localizes to prostate cancer, but also some other cancers as well. It's only approved for prostate cancer imaging in the case of patients who have recurrence. Gallium 68 PET and then F18 PSMA PET, those are both PSMA targeted PET scans that have recently been FDA approved and hopefully will become increasingly available to centers across the country. Choline PET is also FDA approved, but has limited availability. So sodium fluoride PET was listed as the first option in those next generation imaging lists. It's a bone targeted PET imaging modality. It has higher affinity for bone lesions, so it improves the image quality, but it's very much similar to nuclear medicine bone scans. And so sodium fluoride PET, while it was approved, it's not paid for by Medicare. And so it really hasn't been widely adopted since that reimbursement issue has occurred. It is more expensive, has a lower specificity than some of the other PET imaging. And so really it's kind of dropped off the radar. This is a comparison of the difference between conventional nuclear medicine bone scan and then a sodium fluoride PET scan. And so you can see several bone lesions on the conventional imaging, but on the sodium fluoride PET, it's very much more intense and easier to identify those lesions. Now, cell membrane radiotracers like choline and acetate have also been used for PET imaging targets. And so cancer cells have increased cellular membrane synthesis. That causes the radiotracer to be incorporated. Choline is probably the most common of these, but again, it has a very short half-life. So they do have the advantage of having low urinary excretion. And so for patients who have maybe a potential recurrence in the pelvis, that can be helpful. It is FDA approved, short half-life. There is also fluorocholine has the advantage of a longer half-life, so it doesn't need to be, it doesn't need an on-site cyclotron. Again, it hasn't become as widely available. Here is an example of a choline PET study where 358 patients underwent C11 choline PET imaging at the time of biochemical recurrence following prostatectomy. Here are some example images from the choline PET study, and then 45% were found to have positive PET imaging, 66% in the lymph nodes, 34% in the prostate bed, and 29% in the bone. The median PSA for the study was 1.27. If you look though, the PSA cutoff, probably around that 1.5 zone is where the detection drops below 50%. And at lower, below 0.5, the detection was only 20%. So the choline although potentially better than conventional imaging, has a threshold of PSA detection that may be higher than some of the other next generation PET imaging. And then there have been studies where patients have undergone choline PET imaging and then salvage surgery. So this reports on 59 patients who had biochemical recurrence. They had a positive choline PET and then underwent a salvage lymph node dissection. 80% of patients had a positive lymph node at the time of, or positive lymph nodes at the time of lymph node dissection. Median follow-up was 81 months. 38% were able to go without recurrence on PET scan. 59% had a biochemical response. So this is a way that PET imaging has been incorporated potentially into salvage treatments. Now, probably the most widely available current next generation imaging is the Axon scan or F18 flucyclovine. Again, this is a synthetic amino acid. It's a marker of protein synthesis, so it has increased uptake in prostate cancer cells. It has minimal urinary excretion, so that's one thing that may make it easier to detect recurrences in the pelvis. For patients who are undergoing an Axon PET scan, the imaging is done about 4 minutes after infusion. Patients are asked to have a full bladder, so that really potentiates the imaging quality in the pelvis to detect recurrences locally. This Axon imaging or flucyclovine imaging has been approved for detection of prostate cancer recurrence by the FDA. That occurred in May of 2016, and it can detect tumors that are less than 1 centimeter in diameter. Overall, the detection rate is about 68%. In a study of 403 patients, 40% of patients had a recurrence of the prostate bed, 33% in the lymph nodes. Metastatic sites included 26% outside the pelvis, 9% in the skeleton. One of the things about Axon scans is it's not as good for sclerotic bone lesions. And so that is one area where Axon may be limited. But again, because of its minimal urinary excretion, it may be better for pelvic recurrences. And this is just a comparison of flucyclovine versus the old Prostate scan, which was also PSMA directed, but it was scintigraphy, and it was targeting an internalized portion of the PSMA protein. So if you see here, the lesion on the flucyclovine is very evident. However, in prostate scan, it was not as evident. So again, Axon is probably the most commonly available next generation imaging across the country right now. When you compare flucyclovine versus choline PET, they had similar sensitivity and negative predictive values, but the specificity was higher for flucyclovine versus choline, and the positive predictive value was as well. And so for the most part, Axon or flucyclovine has overtaken choline as the next generation imaging of choice. Now for PSMA targeted imaging, we have both F18 and Gallium PET. PSMA PET imaging is targeting that transmembrane glycoprotein overexpressed on prostate cancer cells. This is not the prostate scan that we just talked about, which is scintigraphy and related to the intracellular domain. So this is extracellular. It's expressed at high levels, particularly in recurrent tumors and those with high PSA, or excuse me, high Gleason grade or postoperative PSA elevation. And so here you have a comparison of prostate scan versus Gallium PSMA scan, and you can see that there's an intensity that is very high for Gallium PSMA. So for the PSMA-directed PET imaging, there are two different types right now, Gallium-68 and then also F18. The F18 has a trade name, Hilarify, and so that one is probably going to be the most commonly available. Gallium-68 was studied at both UCLA and UCSF and currently has that FDA indication for those two sites. So here's just a comparison between PSMA PET and choline PET. And you can see in that gallium PSMA PET that the intake is very much higher. And so that is just indicative of how much better that is. And then when you look at the levels of PSA, whenever you can detect metastasis between choline PET and PSMA PET, you can see the comparison at a PSA greater than 2. PSMA PET is still higher at 88% versus 63%. As you go down to levels below 0.5, PSMA PET had a 50% detection rate versus choline PET a 12.5% detection rate. And so PSMA PET, like Axon PET or fluciclovine PET, has overtaken choline in imaging, particularly at low PSA levels. And this is just another schematic. Even PSA levels of 0.2 to 0.5, the detection rate is approaching 60%. And so this is just an additional PSMA study, DCFBC, and you can see where this shows very nicely a metastatic area. Now, as I had mentioned earlier, FDA approval of PSMA PET has occurred for both the F18 and gallium. These are based off of studies that included patients who were high risk, undergoing prostatectomy, and those who had recurrent disease either after prostatectomy or after radiation therapy. So whereas fluciclovine PET has FDA approval in the space of PSA recurrence, PSMA PET will have both a staging and PSA recurrent indication. And so it will be somewhat broader in its approval. Then the last imaging modality we'll discuss is whole body MRI. So the advantage of whole body MRI is that it evaluates the entire body, bone, visceral, and nodal metastasis in a study that doesn't require radiation. It does have better sensitivity than technetium bone scans, but the detection of visceral metastasis may be somewhat limited. The challenge is that it can be technically difficult to obtain a whole body MRI. There is not standard reporting for how to interpret these. And there can be incidental findings that can be hard to discern what is the next step. So the role for whole body MRI has not been clearly defined. Reimbursement is variable, and it's currently, its use is limited. This is an example of whole body MRI. So again, it's very nice because it has imaging of the entire body in one scan and can readily show metastatic lesions. It just comes down to the difficulty of interpretation and availability. In conclusion, conventional imaging is still something that is standard and widely performed. That includes CT scan and bone scan. However, new PET modalities, which are more sensitive for prostate cancer than CT and bone scan, are on the market, and they're becoming increasingly more available. We think that there are potential for improved clinical outcomes using novel next generation imaging, but there is debate about how much this imaging may improve outcomes. So for right now, we have FDA approval of fluciclovine and F18 and gallium PSMA PET. We're just waiting for PSMA PET to be more widely adopted. Which PSMA PET is currently in use? Well, fluciclovine is the most widely available, but again, PSMA PET is probably going to be increasing very shortly as the polarity becomes more available. Clinical trials will be necessary to really assess whether PSMA PET leads to changes in outcomes, and those will be ongoing. So that concludes my talk, and I will now hand it over to Dr. Cookson, who will be presenting next.